Welcome, everybody, to this month's episode of GaitKeepers Journal Club with your host, Dr. Jeff Dikis. Tonight, I'm joined by two very special guests. Dave and Luke are joining us. We are going to dive into something that we don't normally talk about. We are going off script, and like Rich said, we can do it because we're in charge. This is our thing. We can do whatever we want. So, normally, we are following an article, diving deep with the journal author. But this is something that affects our profession so deeply and importantly that we thought it was important to discuss. So we brought on Dave and Luke, and we're going to take a deep dive into the medical legal ramifications of things that affect us on a daily basis. Dave, thanks for hopping on. Luke, thank you guys so much for joining me.
My pleasure. My pleasure. Well, welcome to David as well. David's on our medical advisory committee as well as a big leader in Florida. So thanks for jumping on, David. And Jeff, thanks for hosting this topic. It's super important. And I love to see it integrated more wherever we can, particularly, I guess you and I are in the Iowa meeting there in the fall. And of course, we're at lots of other venues, David knows, and participates as well. So thanks for having us.
Absolutely. Dave, why don't you give just a quick rundown of who you are and where you practice for people who may not know?
Yeah, well, with the introduction music, I think I should probably maybe expand and wear a different outfit, but that's okay. No, so I wear a lot of different hats within our profession that I thoroughly enjoy. I've been in private practice with my wife for the past 10 years, but over the years, I've kind of evolved more and more outside of clinical practice. Largely being involved within organized medicine. So I'm coming off of my term as the president of the Florida Podiatric Medical Association, and I'm now newly elected as a trustee of the American Podiatric Medical Association, which is definitely going to fill my hands with a lot of good work that we need to do within our profession to keep the ship sailing. Also working pretty intimately with PICA, like as Luke mentioned, on the medical advisory committee. So a lot of this work that I do ties into so many different aspects of our profession, and being able to have a seat at a table where a lot of doctors don't necessarily have a seat, but really should be aware of the conversations that are occurring is something that I consider a privilege and an honor. So I'm very much enjoying the opportunity to be here tonight and look forward to our chat.
Absolutely. And Luke, probably don't need much introduction, but just give people a quick rundown of what your current role is with PICA and how that kind of makes you an expert in this field of ours that we're about to talk about tonight.
Well, thanks. I mean, cut to the chase. I'm the chief medical director for PICA. Am I an expert in med mal? I certainly have. Prior to taking on this role 3 years ago, I was on the medical advisory committee under the lead of Ross Taubman for about probably 15 years or so. Certainly have a lot of accumulated knowledge. And then, of course, my whole clinical career. So, I'm an educator. I'm passionate about education and surgery. Sports medicine was my career. My wife's a podiatrist as well. So certainly I'm the medical, clinical, surgical resource in the medical director role. And I love our profession, and it just sort of kills me that we don't make better decisions on a week in, week out basis, and we don't really seem to have learned over a pretty, this is, you guys are doing journal club review of articles and so forth. Let's just call it over a longitudinal observational experience. We sort of continue to make the same errors, all against a really crazily dynamic med mal landscape of plaintiffs' attorneys, emboldened social anger, social inflation, the public just sort of seeing dollar signs everywhere, both advertising and so forth. So I'm passionate about education. That's my role here. Chief medical director, trying to get risk awareness, I like to call it, Jeff. I like to try to sideline the word management. Management to me is too late. That's sort of the problem's already occurred. We need proactivity, risk awareness.
Yeah, I agree with you. So we're going to use this PowerPoint to kind of help drive discussion as some talking points. But I know we are going to run through this hour in a hurry because there's a lot to talk about. And so we may not even get through all of this, but let's go ahead and jump right into it. Like I said, to use these as talking points for us. And I'm sure that'll spur a lot of discussion. So, Luke, you want to take us through this slide and then we'll jump off from there?
Yeah, sure. I mean, the bottom line is you're in private practice, you're doing the best you can for patients day in and day out, and people allege you've done something wrong, right? And so a plaintiff's attorney gets a hold of it, they shop the notes, and these are sort of their theories. All right. And then you've got to defend yourself. And so if you read down the list, and I'm not big on reading slides, everyone can read them. It's all about failing to have done something or negligently this or that. I mean, the bottom line is if you sort of siphon this down, our role in medicine is to educate people. We've got to educate them. And when we don't educate them on all aspects of the care we're recommending, and we're proceeding with, or they're not agreeing to, then what are our recommendations? Well, when something gets sideways, it's the failure to have diagnosed on time, failure to have referred, failure to get them to someone with a higher skill level. We did something wrong, all that sort of stuff, non-compliance. Did we really tell them? So, these are the theories. And then in med mal, of course, you get plaintiffs experts and defense experts, and take a look at the medical record and start to sort through it all with claims analysis and, of course, expert defense attorneys. But these are the common theories. We were too late to do something. We didn't do it correctly. We didn't really recognize a problem, and we did something wrong that was just outside the standard of care, the normal thing someone else would do.
And what my takeaway from this slide is that there's a large variability in the severity. If you perform the wrong surgery or unnecessary surgery, that's kind of hard to defend. Whereas on the other side, maybe if they say you failed to diagnose something or you didn't refer them to a medical specialist, but it had crossed your mind, there's not as much gross negligence there, but you can still be held accountable for these things. Are there any that jump out to you, Dave, as things that, obviously, no, everyone in this listening to my voice right now is going to say, well, I would never perform the wrong surgery. I'm careful, but it happens to somebody. It happens. I always tell my patients, the chance of you getting a blood clot is exceedingly low, but someone gets hit by lightning, someone wins the Powerball. It happens to somebody, right? And so all of these things can affect you no matter how much you protect yourself and how careful you are. Some of them are within your control and some of them aren't. Are there any that jump out to you as that you want to dive a little deeper on?
Yeah, I mean, Jeff, you're right. And I think, the point to make with regard to something like unnecessary surgery or wrong surgery is that just at first glance, it seems egregious. It seems like, well, who would do that? But there are a lot of shades of gray in both of those categories when you truly dive into it deeper. I mean, necessary can largely be subjective. And that's where a lot of things do come down to the expert witnesses on the plaintiff side and the defendant side trying to debate necessity about a particular type of care that's been rendered. When we think about it in the context of being a podiatrist, okay, a lot of times, we might sit here and say, okay, a lapidus is what's necessary to correct this particular deformity. And another expert witness could say that a lapidus was not necessary or was contraindicated because of a patient's, bone density, for example, where there may have been an alternative procedure that could have been more appropriate for that type of care. So necessary in itself, I know it does seem like a loaded topic, but there's a lot of elements of discrepancy between that. Same thing with wrong surgery. A lot of times one doctor may say an amputation is what's indicated here, and another doctor may say no, you just simply needed to perform some debridement of bone or antibiotic therapy. And so certain things that might seem egregious at first glance are not necessarily once you get into the nuance of exactly how the decision was made to proceed with a particular type of case.
Yeah, I think those are great points. Luke, what do you think about how we could protect ourselves? Is there any way that we could protect ourselves? Because there's a difference between carelessness and gross negligence. Sometimes you mean to call the patient back and give them the results of their thing, but you got caught up. I got called to surgery and then I just slipped. And then I had to pick up my kid from soccer practice and then I just slipped my mind. That's not necessarily gross negligence and there's no malintent behind it. What are your thoughts on ways that we can kind of mitigate some of these issues?
Well, so let's start, Jeff, with the understanding for everybody that the definition of malpractice really is that it has to match, it has to meet the threshold of three things, right? There has to be a deviation of the standard of care, there has to be a damage, and there has to be causation. Those things have to connect. So when you the types of situations that you just said doesn't necessarily mean there's a damage, doesn't necessarily mean there was causation, right? And so you just do the best you can in real time. And then the real keyword that everybody has to, particularly young professionals, that first 5 to 7 years after residency or fellowship, your rationale. As long as your rationale for the decisions you're making is clear. And I always say, and I've borrowed it from Stephen Covey's 7 Habits of Highly Effective People, I always give credit where credit is due. Begin with the end in mind. Every single note that you're creating in private practice on a daily basis, you need to begin with the end in mind. And you need to say, well, what if Jeff is reading this note 4 years from now because some plaintiff's attorney, and again, this title of this slide is theories. They got to prove their theory. Okay. They got to prove their theory. They're going to throw lots of things at the wall because it's about money. Okay.
Right.
So if your rationale is clear in the notes, then you're covered. Let's say you pick up your kids and you got a text from a patient and you didn't get that in the note that night or even tomorrow morning. Put a new note the next afternoon. Putting in the note, it can be an addendum or a new note and so forth. Your rationale's there. If I'm reading it a few years down the road, it's like, okay, normal stuff, right? You can't do everything. It's about rationale. I'm going to stop with this because I don't want to usurp the whole conversation. There's 3 C's. If your medical record, your presentation, if you're being deposed, you're on trial, if you match up really well, you sync up well with the 3 C's, do you appear to be credible, competent, and caring in your medical record, in your demeanor, in your tone of voice, in your presentation, in your communication style? Caring, credible, competent. You're going to win every time. And au contraire, when you're not, it's going to be a long day.
Yeah, I think some people are better equipped to check those 3 boxes than some other people. Uh,
Absolutely, absolutely. But they can be learned. They can be learned and polished and skills, right?
Certainly. Uh, Dave, what do you think about the one that says failure to attempt conservative therapy? Because I think that's an interesting concept there of how aggressive some doctors are on getting people to surgery versus not. And that doesn't make them guilty of malpractice in any way. It just says some people are more aggressive of scheduling surgery than others. What are your thoughts on that? Because we're all presented with cases who show up and you're their second, third opinion. They've tried all the conservative measures in the world, and you didn't try any of the conservative measures, but they've already been done. I know that we're falling outside of the purview of what this is intending, but what are your thoughts on that one specifically?
Yeah, and unfortunately, I'm going to go back to a little bit of what Luke mentioned, and it's beating a little bit of a dead horse, but it comes down to documentation. If you have a patient that does present that way, and they admit to you, and it's clearly documented that they have attempted other forms of conservative treatment, if you haven't documented it, there's no defensibility against that. But if you have, especially now in the days of artificial intelligence, scribing, and documentation that can be done on the cuff, it should be very clearly noted in the record that those conservative therapies were attempted. Now, there's obviously going to be some variety to that. One doctor's level of extensive conservative care may be another doctor's, minimal effort. And that's where a lot of times courts have to look at things very clearly and kind of determine again that standard of care guideline. Did you attempt sufficiently to actually perform any type of care or document that that conservative care was attempted before making a decision to move forward with surgery? And different conditions have different levels of that conservative therapy. We know that there are only so many things that can be done, for example, maybe for, let's just say, hallux limitus or hallux rigidus, versus something like plantar fasciitis could have a much broader scope of conservative treatment options. And so with that in mind, I think everything is contextual. Again, it's very nuanced.
I think Go ahead, Luke.
Yeah, here's the key with this, Jeff, to add to what David said. Document the functional limitations of what the patient can no longer do that they would like to do, which is necessitating the decision for surgery. I ask patients all the time, and I recommend everyone do the same. They can pick your own vernacular. What is your foot no longer allowing you to do? And if they give you the deer in the headlights stare, all you do is rephrase it. What have you stopped doing due to your foot or ankle issue?
Mhm.
Number one, if they can't answer those two questions, don't operate on them. You're nuts to operate on them if they can't answer those two questions. If they can answer the questions, document what it is that they can no longer do or what their foot no longer allows them to do. Why? Because that's your out. You've got to be able to show them later that they were not able to do XYZ, which is why after the exhaustion of conservative care, there was a mutual decision to proceed with surgery. It's really that straightforward and alarming that we don't do that on a routine basis.
Yeah, I mean, I think the crux of all this is documentation. If you didn't document, it didn't happen, and that you can protect yourself significantly with adequate documentation. I feel like I go over and above. I will write every single thought that I am having for two reasons. Number one, if there's ever a medical legal situation, I want that in the record. And number two, I tell the students that I work with 99% of the time, the only person that's going to be reading this note is you 3 years from now. And you're going to be like, what the heck did we talk about? What did we do? What did I, it's going to benefit you when you put all that stuff into your own note. Like I said, 99% of the time, nobody else is checking those notes except for you, the future version of you. So yes, we're documented to protect ourselves medical legally, but also you should be doing it to be thorough for your own benefit. You want to talk us through, Luke, some of these most common, most expensive reasons that people end up in one of these unfortunate situations from a medical legal standpoint?
Well, sure. So these are kind of the top two, as you said, Jeff, and it's titled "They're Most Common, Most Expensive." Listen, this is all theater, okay? Plaintiffs' attorneys in the United States are using the courthouse as their own personal casino, okay? And there's a lot of money to be made, and there's a lot of money out there to cast aspersions and so forth. So, most common, most expensive, well, it goes to sympathy, okay? And listen, people have these issues. I'm not belittling it all. What I'm doing is I'm putting a stake in the ground and have been for a couple of years now about awareness around the fact that this is theater. It's a bit of a circus act. And if someone has an amputation, okay, that's very sympathetic. If it's a young patient, an older patient, they, of course, again, theater, they're going to come into the courtroom and they're going to be limping and they're going to be asked to take off their prosthesis and there's going to be a gasp and all that and so forth. And then CRPS, which is horrible when someone gets CRPS, is a huge sort of rainmaker. And so plaintiffs' attorneys, these are the two top ones where it's really off to the races if a patient has had this outcome. Okay, now remember, just a poor outcome doesn't mean there was malpractice or negligence, right? But when they have this poor outcome, these are the ones that cost the most to defend, even successfully. Okay, I can tell you of 500,000 in legal expenses to win an amputation case at trial. That, of course, the plaintiff's attorneys were wanting, in excess of policy limits, right? So, you know, the other thing with amputation is there's lots of opportunities for the plaintiff's side of the equation to go through the entire medical record and say this was missed, this wasn't done, this was too late, infection, lack of referral, vascular ID, and so forth. And then CRPS. I'm going to say one thing here, and please, I hope every listener, I see 121 people on there. What you got to do with CRPS is you have to, along the way, sprinkle in the pertinent negatives. The pertinent negatives. Get the Budapest criteria for CRPS. Read it. Have it in your medical record. Have it in your office. And as you're seeing these patients who may have more pain than usual after surgery, be sprinkling in the pertinent negatives so that down the road, again, beginning with the end in mind, when someone's coming back and looking at it and a plaintiff's side of the equation, attorney, plaintiff's expert wants to say, Dr. Dikis missed this. He missed this. And you go, not so fast, cowboy. It's all in there. I said on March 8th, 2020, no sign of allodynia, no vasomotor instability, no trophic changes, etc. You get my drift.
Yeah. Yeah, and I think this is difficult because if you practice long enough, you're going to have patients who go on to amputation for whatever reason it may be, and you're going to see patients with CRPS. It's just the nature of if you see enough patients, you're going to see these things happen eventually. So that doesn't necessarily mean that you are at fault. It might, you may have done something wrong. But Dave, what are your thoughts on these two in terms of Luke kind of hit it on the head of documenting, and that's going to be a common theme throughout the evening of, be aware of these possibilities and document it. Hey, I was thinking about this, and if I would have seen this or this, I would have done something about it, but I didn't. So what are your thoughts on these two?
Yeah, I think at the end of the day, defensibility comes down to what steps did you take to mitigate or hopefully prevent the possibility of that outcome from occurring. And as both you and Luke had mentioned, if you see something headed in that direction, but you've taken the appropriate steps, you've done perhaps co-management with infectious disease or a vascular surgeon, you integrated appropriate care for CRPS with a physical therapist, getting them on board very quickly. All those types of interventions, when they're executed at the right stage of care, if in fact they ultimately do lead to that outcome, are going to stand and carry a lot of water in a court to defend your case. And I think that's the ultimate point to make. I mean, a lot of the folks that I see in the chat here are, or on the call tonight, are younger practitioners who are trying to learn the ropes and trying to learn what they can do to keep themselves out of hot water. And just as you mentioned, Jeff, these outcomes are going to occur. But if you take the appropriate steps along the way to at least show that you made the appropriate efforts to prevent that outcome from occurring, it's gonna stand a lot of make a huge difference ultimately in a court of law, if ever it were to get to that point.
Yeah, I just want to bring up a point that I was thinking about while you were talking. I think it's important for younger people. So early on in my career, I'm thinking specifically of blood clots and the risk of DVT, but it made me think about CRPS when I'm looking at this picture here and thinking about one thing that you could be held accountable for is if someone did have a history of surgery and had a history of CRPS and you didn't realize it or didn't ask. And so early in my career, I was kind of waiting for patients to tell me if they've had any kind of issues in the past, specifically DVT, history of blood clot, PE, whatever it may be. And one time, luckily, no issues, but I had a patient who did have a DVT, and then they came back later and said, "Well, that happened after my first surgery too." And I was like, wow, I didn't even, I figured you would bring that up. That feels important
Yeah.
to me that you would tell me that,
Would
but
have
it's
been nice
not.
to know. Yeah.
Yeah, I was like, that feels like something you would have been like, oh, hey, by the way. But now I have this huge uh, checklist of questionnaires like, do you have diabetes? Are you on any of the Ozempics or any of the GLP medications? Like everything that's going to potentially affect my outcomes. Have you ever had a blood clot? Have you ever had a PE? And I catch things all the time there, and they don't tell you except then you ask them, they're like, oh, I guess it was like 25 years ago. I did have a PE. And you're like, okay, hold on. Let's back up a minute. We got to reassess everything from this situation. What are your thoughts on? I do not have CRPS on my checklist. And I think if I ask patients, they'd be like, I don't even know what that is. What are you talking about? Luke, what do you think about a checklist of how do we I'm trying to think, I'm trying to spur the, or spin this in a way of yes, these things happen and sometimes they're unavoidable, but what can we do as practitioners to try to limit our risk associated with that? Do you think CRPS is something we need to be asking patients about? Like, hey, if has this ever happened to you?
Well, so I commend you, Jeff, for everything that you just said, because what you just preached was situational awareness and risk awareness at this point in your career that you say, perhaps you didn't have early on, nor did any of us, right? And so I have another slide in another talk where I add the word risk on the intake H&P form, like let's say a new patient, or, if you're in the hospital, you're admitting a patient or something, and I put it right under allergies. And I always say, well, why do we ask about allergies? And it's because, well, if someone's allergic to something, they could die, right? And so I put risk right under it. I go, ask them about all sorts of things, just like you said. Now, specific, your question was about CRPS. You're right. They're not going to understand the acronym CRPS, right? But how do you do with pain? Have you had any other procedures? And you, of course, extend the conversation to their family. That's a great little pearl right there. Extend this conversation to the family. Do you or anyone in your family have trouble with pain? Have you had, you can make stuff up. You had a dental procedure. Did you do okay? Have you had previous surgeries? Are you a nervous Nelly? I mean, everyone needs to create their own sort of conversational manner of talking to patients. And you do after that, probably first 1 to 2 years of private practice, you feel real good with your own script, right? But just get these questions out there. I like to ask people and they look at you a little weird, but it develops a conversation. I go, do you have any risky habits? You like to bungee jump? You like to four-wheel? When people look at you and I'm like, hey, I just need to know, like, what do you do? How do you get your thrills, right?
You're
And then you
selling them
start,
life insurance. You selling them life insurance? What are you into?
you know what I'm trying to do? Avoid problems. Why do we ask about allergies? Why do we ask about intolerances, right? Because that's where things go sideways. And I always say, we'll never know the answer to the questions we don't ask. So just ask them. People are going to see the top 6 here. This is only 2. Take the top 6. Ask these people ask every patient you see from in the future these 6 things, and you'll be basically probably 98% protected.
Dave, do
Yeah.
you ask about CRPS or history of DVT, all that stuff? How do you handle that with your patients?
So, for me, and I'm very much in a protocol driven environment. My wife and I have established a practice that is largely driven by protocols, and that is no exception with regard to how we handle preoperative management, especially for elective surgery. And that does involve questionnaires. We as surgeons, especially with the malpractice climate that we have and the nature of healthcare today, are in fact gatekeepers. We are. And the onus in some cases should be on a patient to actually prove
Well
that
done,
they are
David. Well
in
done.
fact, yeah, that they are in fact, and you can use that on social media if you want to. But the
Oh,
fact that
yeah, it's already been launched.
there you go. I love it. But ultimately that they are in fact worthy in some ways of proceeding with elective surgery under your care. And you do that by incorporating things like questionnaires, and patients, if in fact they're motivated, are going to complete it and provide you the information that you need to make safe decisions. And a lot of times if patients get frustrated by your 3 or 4 page questionnaire that does ask something like, do you have a history of CRPS? And they start to, they're calling, they're texting, they're asking you, doctor, this is a headache, blah, blah, blah. You may learn very quickly that that's a patient you may not want to do surgery on because of how much of a headache they are preoperatively. Going through a standard questionnaire is commonplace in many different fields of healthcare. So we should be no exception to that rule. And I'm certainly not in my practice.
Very reasonable. Thanks for the gatekeeper shout out there.
Right.
All right, Luke, take us through these next 2 and we'll break them down 2 by 2.
Well, so there's a common denominator, right? You can die from these, okay? And wrongful death allegations take an awful lot of work to defend, okay? So that's why they're expensive. And, of course, the element as well is that if unfortunately and tragically a patient is deceased, you're now dealing with the descendants, okay? And so you're dealing with other folks who aren't necessarily even that privy to what was going on with HIPAA rules and this and that and so forth. But the reality is that both of these can largely be avoided in a similar way of what David just said with protocols, certainly around the possibility of DVT and PE. Okay, now sepsis. Look, the NASCAR driver just died recently, tragically, of sepsis after it sounded like pneumonia or something like that. I mean, some of these things are off to the races, right? And they're very, very quick. And our job on the medical side is recognition and education specific around DVT and PE. We created a form at PICA. It's available on the risk management section of the website where it's basically the signs and symptoms and risk factors for DVT-PE. Every patient should get 2 copies of it. They should sign 2 copies. One gets signed and left in the medical record in your office. The other gets signed and taken home. Then, when they get the signs and symptoms at 3 in the morning, they've been educated. They know it was all discussed, what they need to do. And then the thing with biopsies of skin lesions, okay, you should biopsy anything that's suspicious. Every now and then at a live lecture, someone will go, "Oh, Luke, that's crazy. My patients complain." Well, doc, you've done 8 biopsies and they're all negative, and they're complaining about the expenses for it. I say the only appropriate response is, and thank God you don't have cancer. Okay. And
Yeah.
thank God you don't have cancer.
Yeah.
So proactivity. And I'll say one last thing about DVT-PE. You got to update the questions on each visit. You have to re-ask them. Okay. It's not enough to do, let's say, David, screening and then never pivot back to it on each subsequent postoperative visit, because life happens in real time. So the key there is each postoperative visit, you ask the same series of questions: swelling, redness, shortness of breath, calf pain, etc. You gotta stay contemporaneous with your medical records, as well as your questions and your awareness around risk through the longitudinal care of the patient.
Yeah, Dave, how do you handle DVT and PE? If we look at the research in the lower extremity, it doesn't actually support any DVT prophylaxis. When you get up into the hip and knee, that becomes very different. But for us, but that doesn't necessarily mean that you just don't have to worry about it. Oh, if they get a DVT, that just happens. That's nothing that you had control over. How do you handle that discussion about that, and checking for risk factors for people who may be at higher risk, and treating them differently than just the average person who's young, healthy, with no risk factors?
Yeah, so exactly as you mentioned, I mean, I don't incorporate any, anticoagulation therapy above and beyond what a patient may currently be taking for a particular condition. The nature of my practice is such that I'm not doing particularly complex reconstruction. The bulk of the work that I do is minimally invasive surgery at this point, where I'm not using a tourniquet. And in the case of, risk of DVT, if I have a patient that has documented a history of it, I obviously, reflect that in the type of care that I might render or co-manage with either a vascular specialist or a primary care doctor. But again, even questionnaires, and when I'm getting preoperative clearance through their primary care physician, part of the information, part of the packet, if you will, or survey that's sent to that primary care physician, in fact, requests a check mark from that doctor about, are you aware of any history of DVT or PE for that patient? So even if the patient themselves doesn't admit to it or document it, at least I have the primary care doctors also vouching for that. And if in fact that there's a situation that, where clinically I'm appreciating signs or symptoms of either, it's about taking the appropriate steps to manage it and get that patient either into an emergent care setting, or co-managing again with primary care or a different specialist in a very rapid fashion. I don't hesitate to take the steps quickly, and I've had this happen, several times over the course of even just the past several years, where I tell the patient, listen, we need to get a stat ultrasound, we need to have the assessment done just to rule it out. Kind of like taking biopsies to determine whether or not there's any evidence of malignancy. You should just do it and be thankful for the negative outcome. And I've never had a situation where a patient has come back and said, "Oh, what a pain in the neck. I wish you hadn't have sent me," for a negative outcome. It just doesn't happen. So I think if you have any clinical suspicion, you just have to use your spidey sense and move forward with it. I do want to make a quick comment though about the skin lesions, if we're still on that topic. We as a profession, by and large, are grossly negligent at taking just biopsies in general, let alone when we suspect malignancy. There's a very well cited statistic that podiatrists, by and large, average about 4 biopsies per year, when the average dermatologist is at least taking 500, even in a cosmetic type of practice. And with our specialty largely encompassing about 25% of the skin surface area of the human body, we should be taking a much higher proportion. So there's really no excuse for this, but we largely are trying to defer or postpone. And deferment and postponement is what gets people into hot water with these skin lesions when timely assessment and timely care are not rendered. So we've got to do better. And I'm encouraging anyone at all in practice, I don't care what stage you're at, you've got to be looking a lot more critically at these lesions and taking the appropriate biopsies.
I think the hard part about that, and you are correct 100%, but I think the hard part about that is when people go to the dermatologist, they're expecting to get their skin evaluated. Sometimes we're noticing these lesions and someone is there for something completely different. They sprain their ankle, and then you start looking at like, hey, look, what's this over here? They're like, yeah, don't worry about that. I came here for my ankle. So you are correct, but sometimes we're just noticing things, and I think the patient's a little bit caught off guard. Like, well, I didn't really come here for that. I came here for this. Let's talk about that. That doesn't mean you shouldn't have that conversation and recommend it, but I do get when I recommend it, I do get a decent amount of pushback. Like, oh, that's been there for I don't know, that's been there forever. I don't know, whatever. Let's just leave it alone. I'm like, okay, well, at least if you document, take pictures, put in the chart. That's what I do. Take a picture, put in the chart, document it. Say, hey, we recommended biopsy. They declined. That's up to them. We can follow up on that in the future. Um, I did have, interestingly, a 28-year-old male with a fifth metatarsal shaft fracture. I was treating non-operatively, develop a femoral venous thrombosis. He came in. He said, "My foot feels better, but my thigh, my groin is really hurting." And I just thought it was the weirdest thing ever. Like, you could easily chalk that up, like, what do you? Just the boot was throwing off your hip. I don't know, but I ordered a venous duplex, and sure enough, he had a whole cascade of venous thrombosis through his femoral area. So just because people are high risk, I would put him in the almost zero risk category, non-operative, young, healthy, non-operative fracture, no risk factors, otherwise no history of clotting. Then we have to worry about, okay, we need to get hematology involved. We need to figure out, do you have any kind of underlying congenital issues here to talk about? So, Luke, what are your thoughts on? I think that's one of the biggest worries of people is like, well, what should I do to protect myself medical legally from a DVT PE situation? Like, should I be giving them something, but the literature doesn't necessarily support that? Should I give them it anyways? It shows that I care and that I am aware of it. Or what are your thoughts just seeing it from your side of these events when they happen? What do you think people should be doing?
So basically, I'll give you 3 bullet points, okay? The first of all, you have to understand, it will be a wrongful death allegation, okay? It will be a wrongful death allegation. That's the terminology. So how do you protect yourself? Well, you risk assess. Okay. There's 2 or 3, 2, 3, 4 assessments out there. Pick the one that your hospital is using, your surgery center is using, and so forth. Be consistent with the environment that you practice in and risk assess these folks. If they don't need to be prophylaxed, then don't prophylax them. Document your rationale. That's number one. Number two, again, the document I said that's available. This is all about education. We cannot prevent the world from happening around us. It's kind of like stoicism. We can only react to what's going on. We can't control what goes on. So it's about education. Every single patient that gets immobilized, goes into a boot, goes into a cast, is a postoperative patient. They go home with the signs and symptoms and instructions of what to do if they suspect, because of the signs and symptoms, that they have a DVT or a PE. Then you're covered, okay? Because they've been informed. You've got a signed copy in the medical record. They have a signed copy at home. It saved a patient of mine in Arizona, saved her life. I did 2 ultrasounds that came back on her after a plantar plate repair because I suspected a DVT about 4 weeks after surgery. Ultrasound was negative. I said, let's repeat it. Ultrasound was negative. Okay. I said, I want to see you back in a couple of weeks. 10 days later, before she came back in, she told coworkers at work, she said, I think I'm having a PE. And they're like, what on earth are you talking about? She goes, Dr. Cicchinelli gave me this sheet, and everything that I'm feeling right now is on this sheet. And they medevaced her to a hospital in Scottsdale, Arizona, saved her life. And she never, there was nothing, no antagonism or anything. She thanked me. It's about education. And then the third thing, Jeff and David and everybody listening, is really important. You've got to close the communication loop. So let's say you're out to dinner on a Friday night and you're covering call for a partner. The partner patient calls in and, hey, I saw Dr. Schweibish last week. and everything was fine. He's going to see me back in 2 weeks, but something's changed. And you say, hey, I'm on call. I don't really know your situation, but it sounds like you could have a DVT. You need to go to the emergency room, and we need to get that checked out immediately. You got to close that communication loop, and then you're safe. How do you close it? And you text me or call me when you arrive there. And when they do, you document it. When they don't, you document it. Because what happens, and we see it, is they go home, and guys are the worst. They wait in the ER for a few hours. They go home. Their wife says, well, what'd the doctor say? Well, I didn't wait around. I'm going to go tomorrow morning. The ball game's on. The Yankees are playing. I'll go in the morning. And they die at 4 a.m. Okay. So you've got to close those communication loops. And this slide, by the way, goes right back to slide number 1. Okay. Because what will you be dinged on? That you missed it, that your failure to diagnose it, that your failure to act promptly, okay? Your failure to act in a timely fashion.
Definitely. All right, next two here: permanent nerve injury and serial surgeries with unsuccessful outcomes. Take us through this one, Luke.
Well, so let's start with number 6. You know, you got to ask for help, okay? It's absolutely within all of ours skill set, and I think it's the correct path, indisputably. If we have a complication, let's take a hallux varus to address our complication ourselves. We know what we did. We know the patient. We know our preferred techniques and so forth. And so, yes, we have the relationship. We should handle our own complications and so forth. But please, folks, when you're getting ready to operate on the same patient, the third, the fourth, or fifth time when we see these cases, put yourself in the patient's shoes. Okay, what would you be thinking? You'd be thinking, this Dr. Schweibish doesn't have a clue. I've really lost confidence in Dr. Schweibish. No offense, David. Okay, but just put yourself in their shoes. Okay, so you've got to say, hey, listen, I want to get a fresh set of eyes on this. What I found in my career is patients respond very favorably to us demonstrating some humility, to ask colleagues for opinion. I always tell young practitioners, when you first get out, build that network early. You don't want to be passing off problem patients to the colleague across town, and so they're always just seeing a train wreck. No, you get consults early, you get second opinions, and you build rapport. Okay, so you can't be operating on the same patient more than really twice without really starting to get sideways. And then permanent nerve injury really goes back to, it's a cousin or analogous to what I said about documenting functional limitations before you operate on somebody. Be sure you document very well what sort of paresthesias or anesthesia or dysthesias that they have before you operate on them. Because they're sure as hell going to pin it on you down the road. Okay. And yet, if it's in the record beforehand, then, and it's clearly there, then you're saying in your conversation is, well, so you already have this. We're working on a different issue. You're still going to have that. It just has to be clearly documented and you'll be fine. But these are the most common. And why? Because docs fall down in defending themselves proactively. And so it's low-hanging fruit. If you're a planes attorney, you're like, man, this is low-hanging fruit. I'm going after that.
Yeah, I had a patient one time who had surgery and then had some numbness and tingling and said, yeah, she wasn't accusatory, but she had it kind of inferred that it was from the surgery. And I literally in the room, I scrolled back to one of her preoperative notes and I showed her right there and it said, look, I documented that you had numbness, tingling, and burning along this nerve
Perfect.
before surgery.
Perfect.
And then
Perfect.
she's like, "Oh, yeah, okay, yeah, maybe I did." Like, they don't even remember. It's not even like she was accusatory. It was just like, in her mind, it's numb and tingly. I had surgery. It must be because of the surgery. And I had to go back and be like, no, 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 look, you told me that here it is right in the record. So documenting all that stuff is very important. Again, the consistent theme. Dave, what are your thoughts on either of these two things?
Yeah, and things happen. I mean, iatrogenic nerve injury is unfortunate. Something is a circumstance that can occur, and the key, like with most things, is simply to be transparent and honest, document well. In the event of, for example, a tarsal tunnel case, you transect the tibial nerve. If you're not skilled in complex nerve repair, this is in a circumstance where you obviously close the case, you make a stat referral to a nerve specialist who can potentially perform that nerve repair, and you have a very, just straightforward conversation with the patient and say that unfortunately the case of this particular case led to an outcome where this nerve was transected during surgery. It was a very tight space, yada, yada, yada. Hopefully, you had that conversation with the patient preoperatively and let them know that it was a potential risk. And if that's the case, and this were to obviously come before a court, if you've taken the appropriate steps, again, having a bad outcome does not mean malpractice. It's about, did you take the appropriate steps to handle it postoperatively and document it accordingly?
For the sake of time, I think we could spend a lot more time on each of those, but for the sake of time, we're gonna move forward to this one, and then you want to go through this relatively quickly, Luke, and then we'll get to the next slide, which I think will be some of those interesting talking points.
Sure. So generally, when you look at it, it's about knowing your own skill set, your ability to be an effective communicator, and then understanding to drop right down to the collect dollars carefully. Patients sue people that they feel like have abandoned them, or money becomes a big issue. And then if you just sort of reverse engineer that, patients don't tend to sue doctors that they really like. They feel like they've got great communication skills. If something wasn't acting correctly, they referred them out. They investigated a little bit more. They, I've got a doc friend who called me the other day and we were talking about stuff. He goes, I still call patients. Sometimes I'm driving home from the gym and I'll say, hey, I was just thinking about you. And why don't we try this and that? And he goes, patients love that. He's being a good doctor. He's being a good communicator. And you've got to be responsive. When patients feel like they're being blown off by yourself or your staff, particularly in the face of a complication, then they get a big bill or there's a big deductible or something like that. And this is about knowing your staff and, David said operational protocols and so forth. Those are the timeless risk management tips. It's about, you know, stuff happens. Okay. It's about how you respond when it happens to keep that patient as if it was you or your own family member. Okay. What would you want? You want information. You want to know what the plan is, and you're going to be fine. But when patients don't perceive that, you're going to have problems.
Absolutely. If anyone has any questions, go ahead and throw those into the chat. We're going to take the spice level up a little bit here. Um, let's talk about these. Luke, you want to take us through some of these, and then we will talk about, we'll see where it goes.
Absolutely. So, yeah, a little spicier topics, but I think that in the spirit of awareness, we need to realize that there's lots of factors out there. And the first thing I would say to you is that the average foot and ankle orthopedic surgeon, there's 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 probably not a single one in the United States who doesn't privately believe that they're better than any podiatric foot and ankle surgeon. Okay. So be aware of that. Okay. Why? Because we interact with lots at meetings and in industry events and so forth. And I consistently see them. That's why I call them frenemies, essentially, quote unquote, turning on what you might believe is some sort of collegial friendship. Okay. So be aware. I like to say orthopedic surgeons who do foot and ankle surgery and podiatric surgeons who do foot and ankle surgery, and I'm Italian, is like olive oil and balsamic vinegar. They go great together. They do not mix. You cannot get them to mix. Okay. It's chemically impossible. One's hydrostatic, one's hydrophilic. Okay. The only time they ever mix is in about 3 different environments that I've witnessed in my 30 plus career: the VA, the military, and in a Kaiser type system where the competitive juices around the economics of payment and so forth is neutralized. Okay. So be aware. And I have it right there. I put that in there. Typically academic orthopedists and so forth, they are constantly creating problems for us. So what do you do with that? You heighten your awareness. If you live in that type of environment, if you practice in that type of environment, get second opinions early, even before operating on someone. If you lose that patient to somebody else, so what? Okay. What you want to do is begin with the end in mind. unethical colleagues giving BS opinions. This is just crazy, but it exists. Okay. You got to remember something. I tell colleagues all the time, there is no case if your medical record is great and your clinical care is great and everything shows you to be caring, credible, and competent. Why? Because it's not the plaintiff attorney who decides that they have a case. They shop the case, okay? And there is no shortage of colleagues who will be happy to stand up and say all sorts of things. And I also blame American healthcare for this because it's an attractive alternative income stream, okay? It just is. It's an attractive alternative income stream. And so people will lie for money. People will be disingenuous for money. And certainly there's a role for policing our own. So it's not like there's no necessity of good people opining in favor of patients who have had a disservice or a complication or negligence. Absolutely. But in general, there's an awful lot of the other as well. Okay. So be aware. The direct to consumer marketing is very interesting, quite frankly. Okay, Lapiplasty, these types of companies and so forth, which is all great. You just have to realize in private practice that social media, direct to consumer, all of this information is heightening the expectations around procedures, and the public expects perfection and they expect outstanding results from anything, and it's unrealistic. And the plaintiffs' attorneys across the country have caught on to that and are very effectively um, getting traction with cases that never existed, 10 years ago before this onslaught of advertising getting directly into people's homes. I don't want to take all the conversation there. David or Jeff, you're the leader here. So
Yeah, I mean, I think one that I'd like to hit on a little bit more is about, the conversation pertaining to our unethical colleagues as any kind of plaintiff experts. I mean, you're exactly right. People will lie for money, and I think it does come down to economics. The most dangerous experts are really not the ones who fabricate the facts. I mean, I think those are the ones that are usually relatively easy to impeach in a court of law, especially when they do it habitually. The most dangerous ones, in my opinion, are the ones who kind of cherry pick their standards. They cite the literature that's kind of on the fringes or the outlier of common areas of understanding of standards of care. They apply a standard of care that no reasonable practitioner actually follows, but they have an excellent means of sounding authoritative in front of a jury. These are the people that are quite dangerous in the plaintiff's experts world. And there's a specific pattern that I seem to have appreciated. A lot of times, and it's not a true generalization, but it seems to be these are the retired or semi-retired physicians who
yeah,
are trying to supplement their work. They're no
100%.
longer, yeah, they're no longer current in clinical practice, and so their exposure to the modern evolving standards is limited, and their financial dependence on the fees creates kind of like a structural conflict of interest that is rarely disclosed or examined very adequately. And now sitting on the board of trustees for the APMA, I do know that we have these ethics codes in place to technically prohibit false testimony, but I do know that these are very rarely enforced, and I think that they should be enforced more commonly at the state and at the national levels, and that would largely help to mitigate some of this from occurring. So I think when we look at these individuals in the profession, who they should be pointed out for what they are. And unfortunately, they're kind of a plague. And so hopefully, as more and more of this comes out, social media does its job, then we can help to kind of work against it.
Can you guys give me that list of people, and I'll make sure I put that
Yeah.
on my Instagram, and I'll take care of that for us.
Sure.
Direct to
Yeah.
consumer marketing is very interesting. Uh, we don't have time to go into that much further, but I think money is the root of all evil summarizes this here. If people are willing to badmouth other people for money, and the other thing is what makes someone an expert? Like if a plaintiff attorney just finds someone who is willing to say what they want them to say, and let's be honest, that's all that's really happening is the plaintiff attorney wants someone who will say XYZ and they will pay them to say that. But what makes someone an expert? Like, should we have a panel of like, no, that guy's not actually, or a gal, but that guy's not an expert? Like, who makes these people an expert and they can just get up there, say whatever they want, and then take the paycheck and go home? Uh,
Exactly,
baffles my
Jeff.
mind.
Exactly, Jeff. It's baffling. And actually, what it does in the MPL world, or the medical professional liability world, and not just specific to podiatric medicine and surgery, but all medical specialties, hospitals, surgery centers, everything, is it puts the pressure on the insurers to figure the correct path forward essentially a cost benefit analysis, right? And that's the game. Okay, that's the game. And remember, the attorneys don't ever not get paid. Okay. The attorneys on both sides don't ever not get paid. And so there's an awful lot of money being exchanging hands there, and an awful lot of sort of sub-ethical or unethical sort of interest in keeping this little circus going forward, and perhaps testing the resilience of an insurer as to how much fight they're going to apply to a certain thing versus a settlement or a mediated settlement, a mediation.
It all comes down to money. Let's
Yes, it
talk
does.
about these last three here. We have a few minutes left. If anyone has any questions, throw it in the question and answer. Let's go through these last three real quick, and then we'll wrap it up.
Well, so I'll just jump in with the last one and work up malpractice premiums. If I was coming out in practice today, I would literally, just like you might look at the cost of living, like taxes, or, if you don't want to pay state income taxes, you might say, well, I want to live in Florida or Tennessee or Nevada. Or if I don't want to pay a high HOA fee, I don't want to live in the Big Apple. Okay. I don't want to pay New York state taxes. I don't want a concierge. The same way you might think of any other cost of living type things, I would absolutely factor in. Boston's a very expensive city, okay? Look at areas. Malpractice premiums are like any other cost of living. Malpractice premiums are risk pooling, okay? And they're a lot lower in different areas of the country than others. So I would factor that into my decision making. Third party litigation financing is a big sort of ding, ding, ding awareness. Okay. We live in capitalistic America. It's all about money. Okay. And private equity is now pooling funds to actually see, again, sort of like the courthouse is a casino, to see how much money can be made. Now, the old line, if you're a parent, right? There's three truths. There's your truth, my truth, and the truth, right? Well, so on their side, the truth, they will say, well, we're evening the playing field because not everybody has the deep enough pockets to defend themselves in the United States. Okay, well, fine. Okay, but in that may be true, but it's also true that they're enabling plaintiffs' attorneys that wouldn't have adequate funding or need more funding to get suspect or potentially frivolous cases, to a bad podiatry joke, to give them legs, okay, get them off to the races. They're allowing that. And then there's, just like any private equity type venture, they're hoping for financial return on the other end. David, do you have anything to think of? I know we're at the 9 o'clock here, but thoughts on any of that? You got an MBA. What about what I said about malpractice premiums, like any other aspect of cost of living?
It's highly relevant. I mean, and this is a point that I make when I speak with students, residents, and fellows all the time. You've got to put a lot more thought into where you practice, simply on that one factor. Here in Florida, where we're at, we have very meaningful tort reform. We have caps on non-economic damages in certain contexts, expert witness requirements, pre-suit investigation requirements. And all these things really reduce that litigation frequency and the severity when you compare it to other states without these protections. And it's largely why I decided not to practice in Chicago, unfortunately, despite it being one of my favorite cities on planet Earth. I did that analysis beforehand, and when you look at these malpractice premiums, and when they comprise potentially 10 to 20% of a physician's net income over a given year, particularly in private practice, that's significant financial oversight. You have to look at that very critically when you decide where you're going to practice, and if you don't, you're costing yourself quite a bit.
That will bring us to the end of the hour. I want to thank you guys so much. This has been fantastic. We are joined by quite a few people here, and then I will put this on the Paw Patrol podcast feed, so many, many more people will hear it, because I think it is of utmost importance for people to hear this and talk about this. It's not something that's commonly brought out into the public. Luke, thank you so much. Like you said, you came to Iowa and you put a spin on it from that standpoint on all of our lectures. And and gave us the behind the scenes of how to protect ourselves and the do's and don'ts and all that stuff. So I really appreciate your passion for this and bringing awareness to this particularly important topic. David, thank you so much for joining us as well. Also an expert in the field. And Rich, thank you for hosting.
Thank you,
Yeah, that
Jeff.
was knockout episode, guys. Really, just so practical. Like, I think that's what I really liked. I mean, so practical, things they could apply the next day, right? These are tips and tricks they can apply the next day.
Yeah, and as Jeff referenced earlier, I mean, this is a topic that you can make multiple episodes out of. So happy to come back and continue the conversation.
Oh, we could talk a few more hours about these things and certain scenarios with trauma surgery versus elective surgery, and where do you live and where do you practice, hospital privileges, surgery center, you name it. Even things in the office, harassment, angry patients, all that sort of stuff. There's so many things that could be talked about. So
No question. There you go, Jeff. There's a few more topics down the road there, brother.
Absolutely. We will circle back, I'm sure. So I just have to say this part for the podcast. Thank you, everyone, for joining us on this episode of Gatekeepers with your host, Dr. Jeff Dikis, joined by the aforementioned gentlemen. Thank you, guys.
thank you, Jeff.
Guys. For sure.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.